Hello students. So today we are going to discuss 20 short questions from pediatrics, right? Consider them as 20 short topics in the section of pediatrics for your FMG exam. FMG exam is right down the corner, right? And I know you all have studied well throughout the 19 subjects. As far as pediatrics is concerned, I have curated this video in such a way that most important topics are covered, right? So if you are preparing for pediatrics, if you are revising pediatrics, then make sure these 20 short topics are not missed, right? So let's briefly go through these topics. Let's learn and revise what are the important MCQs that are frequently asked in the exam. So the first topic here is neonatal resuscitation protocol. When it comes to neonatal resuscitation protocol, remember the algorithm. Can you see some things are there in the boxes, some things are there in the diamond shape, right? These diamond shapes are the questions that you are going to ask, and the squares are the actions that you are going to do. So prior to the birth, firstly we do antenatal counseling and team briefing and check the equipment. How many people there should be available at the time of delivery for resuscitation? Minimum one person, minimum one personnel that is trained in NRP should be there for the delivery. And if it is a high risk delivery, if it is an anticipated high risk delivery, then minimum two should be there. As soon as the baby is born, you ask three questions: term, tone, cry, right? Term, tone, cry. If answer to any of these questions is no, you will start with initial steps of resuscitation. Right? What are the initial steps of resuscitation? You stimulate the baby, right? By gently rubbing the back of the baby or flickering the soles of the baby. If there is any secretions around there, you suction the secretions. You suction mouth followed by nose, right? You dry the baby. These are all the initial steps of resuscitation. After the initial steps of resuscitation, you check the heart rate. If the heart rate of the baby is less than 100, or the baby is apneic or gasping, then that's the indication of starting positive pressure ventilation. This is what they ask in the exam. What is the indication of positive pressure ventilation? If after the initial steps of resuscitation, the baby's heart rate is less than 100 or the baby has apnea or gasping, then that is an indication of positive pressure ventilation. And remember, positive pressure ventilation should be started within 1 minute. Right? This is known as the golden 1 minute. Right? Golden 1 minute. How do you give positive pressure ventilation? Either I can give through bag and mask, which is an easier one, or we can intubate the child and give through the AMBU there, right? So imagine we have started the positive pressure ventilation with bag and mask ventilation. So after 30 seconds of effective positive pressure ventilation, remember 30 seconds of effective positive pressure ventilation, we check the heart rate again. If the heart rate is less than 60, then that becomes an indication of adding chest compressions to your ventilation. And if you have not intubated the child earlier, you have to intubate the child now, right? So what would be the indication for chest compression? If after 30 seconds of effective positive pressure ventilation, the heart rate is less than 60 or the baby is not breathing again, then again we start chest compressions. After 60 seconds or 1 minute of the chest compression, we check the heart rate again. If the heart rate is still less than 60, then we give injection epinephrine, right? If the heart rate is persistently low despite giving epinephrine, we rule out two things. You rule out pneumothorax, right? Auscultate the chest of the baby. If there is no air entry on one side, that would be pneumothorax. In that condition, we do needle thoracotomy. Or consider hypovolemia, consider as shock, and we give IV fluids. Now, important questions regarding this. Bag and mask. Firstly, bag and mask, positive pressure ventilation. In which all children you won't give bag and mask ventilation? Children with CDH, that is congenital diaphragmatic hernia, we don't give bag and mask ventilation, right? Second question. When you start this bag and mask ventilation or positive pressure ventilation, what is the percentage of oxygen that you are going to give through that bag and mask? If it is a term baby, we start with 21%. If it is a preterm baby less than 35 weeks, then we start with 21 to 30%. And we titrate according to the saturation, that is the target saturation. Can you see this boss? Target preductal saturation after birth. Right? Sometimes they ask this target preductal saturation. Very easy to remember: 1 minute, 2 minute, 3 minute, 4 minute, 5 minute, 10 minute. Right? You start with 60%, 60 to 65, 65 to 70, 70 to 75, 75 to 80, 5 minutes, 80 to 85, and then the last lap, 85 to 95. Right? Depending upon the target saturation, we will titrate this oxygen. Then comes chest compressions. What is the rate of chest compressions that you're going to give? What is the rate? We give 3:1. 3:1. Right? So if I have a baby with me like that, I will give 1, 2, 3 and then squeeze. 1, 2, 3, squeeze. 1, 2, 3, squeeze. What I am squeezing the ambu bag to give ventilation. So 3 compressions to 1 breath. 3 compressions to 1 breath. This has to be done in 2 seconds. 2 seconds. Total, there has to be 120 events. 120 events. 90 compressions, 30 breaths. 90 compressions, 30 breaths. Right? So this is about the chest compressions. So most of the questions of neonatal resuscitation protocol have been covered. Read the question carefully. Read the question in a way that you get to know what the examiner is asking. Right? Examiner mostly would be asking the indication of PPV, or would you give PPV or chest compression in the next step. Right? Remember, I said that you have to give 30 seconds of effective posture pressure ventilation. But at times it might happen that the bag and mask ventilation that you are giving is not effective. So how would you get to know that my bag and mask ventilation is effective or not? By looking at the heart rate. By looking at the heart rate. Remember, heart rate, increase in the heart rate is the most effective way to learn. Is the most effective way to learn. Okay. Moving down to the next topic. Short stature. Right? Short stature. The next topic, short stature. What is short stature? Short stature is nothing but a short-heighted child. That means the height for the age of the child less than -2 standard deviation or less than third centile. Less than -2 standard deviation or less than third centile. The short stature could either be a physiological short stature or could also be pathological short stature. Physiological short stature is what is important for an exam. Right? It includes the familial short stature and constitutional short stature. Very important concept, very important concept, very basic concept. Can you look here? Can you appreciate the picture over here? Look at the picture A. Parents are short, that's why the child is short. This is familial short stature, that the entire family is short. Right? The genetic potential of the child is such that the child will be short over here. Right? But look at this image B. The child is short, but the parents are normal heighted. Child is short, but the parents are normal heighted. If I probe into the history of the parents, then when did they gain weight? When did they gain height during their childhood? When they hit the puberty in their childhood? They will also say that there was a delay in my puberty as compared to my peers. I also gained height later on in my childhood. Right? This is nothing but constitutional delay in growth in the puberty. Here the final height of the child is going to be normal as the parents. But right now the child is short. Right now the child is short. Right? So this is the difference between constitutional and familial short stature, which is more common. Constitutional delay in growth and puberty is more common as compared to the familial short stature. History, I just told you, there will be a history of delay in puberty in parents over here. In familial short stature, there will be history of short parents. Final height would be normal in cases of constitutional delay in growth and puberty. Final height would be shorter like the parents in cases of familial short stature. Then comes the concept of height age, bone age, chronological age. What is height age? Height age is that height at which that height is at 50th centile. What do I mean by that? We know at birth 50 centimeter is the normal height of the newborn, right? and by 1 year of age it should be 75. So if I randomly tell you that the length of the baby is 75, you would have guessed that the age of this child would be around 1 year, right? Similar is the concept of height age, right? Just by telling you the height, you can guess the age of the child, right? So here, for short stature, I know height age has to be less. Height age has to be less. So in both of these conditions, height age would be less. What about bone age? Bone age. What is bone age? How do we calculate the bone age? We look at the bone age by looking at the number of ossification centers, right? We take the x-rays of the child and we compare it to the atlas, right? And estimate the age of the child by looking at the bones. If the growth of the child is on the normal tract, that means the ossification centers have fused, then that would be the familial short stature, because this child is growing at a normal pace only. The genetic potential is as such that the final height would be this only, right? So in familial short stature, my bone age would be normal. But in constitutional, there is a delay in the puberty. In constitutional, there is a delay in puberty. That's why the bone age would be decreased over here. The bone age would be decreased over here, right? So very simple, height age would be less in both. When we talk about bone age would be normal in cases of familial short stature. It will be less in cases of constitutional delay in growth and puberty. And if you look at the relationship over here, then definitely my chronological age is more than the height age, and height age is equal to the bone age. And similarly for familial short stature, my chronological age would be equal to the bone age, which would be more than the height age. Remember, height age would always be less as compared to the chronological age to label it as a short stature, right? So I hope all the doubts have been cleared. This is the most important concept over here: physiological short stature, constitutional delay in growth and puberty versus familial short stature. Then comes pathological short stature. Pathological short stature can be further divided into proportionate and disproportionate short stature. Proportionate, you can easily imagine that proportionately the child is short. Proportionately the child is short. That means the upper segment is also short, lower segment is also short. We all understand what is upper segment, lower segment. If this is my child, then the upper segment is from the top of the head till pubic symphysis. This is the upper segment. And the lower segment is, if I subtract the upper segment from my total height, that would be the lower segment. If the child is proportionately small, the upper segment is also small, lower segment is also small. That means my upper segment, lower segment ratio is appropriate for that age. This would be proportionate short stature. This we usually see in malnourished child with growth hormone deficiency, or children with chronic illnesses like CKD, CHDs, right? In all of these children, because the overall growth is delayed, overall growth is halted, I would have a proportionate short stature. On the other hand, what about disproportionate short stature? What do I mean by disproportionate short stature? Disproportionate short stature means either the upper segment would be affected or the lower segment would be affected, right? Let's look at what all conditions the upper segment would be affected and what all conditions my lower segment would be affected. To understand this concept, you should know what is the normal upper segment to lower segment ratio. What is the normal upper segment to lower segment ratio? We all know that at birth, what is the normal upper segment ratio? It is 1.7:1. That means my upper segment is big as compared to my lower segment. But as we grow, our limbs grow and our lower segment grow. So proportionately, our upper segment becomes smaller. By the end of 3 years, it's 1.3:1. By the end of 6 years, it's 1.1:1. And by 10 years, it becomes 0.9:1. 0.9:1, or the adult ratio, that is also written as 1:1.1. This is the normal, right? But if you notice that the upper segment lower segment ratio is higher as compared to the age. For example, at 3 years of age, I know my upper segment lower segment ratio should be 1.3:1. But if you notice, by assessing the child, by measuring the child, that the upper segment ratio is 1.5:1. That means my upper segment lower segment ratio is more as compared to my age. That means the upper segment is big, limbs are small, right? Lower segment is small. What is this? This is short limb dwarfism. Short limb dwarfism. And in short limb dwarfism, you need to know three conditions. These three conditions you should be able to recall even in your sleep. What are these three conditions that affect the limbs? Rickets, achondroplasia, and congenital hypothyroidism. Congenital hypothyroidism. Congenital hypothyroidism. Right? Moving down to the next condition where the upper segment lower segment ratio is less as compared to the age. Right? I gave you an example that at 3 years normal ratio should be 1.3:1. But if it is 1.5:1, that's high upper segment lower segment ratio. That means short limb dwarfism. On the other hand, if it is low, that means, for example, at 3 years of age the ratio is 1.1:1. That means my trunk is short. This is short trunk dwarfism. All the spine conditions. Our trunk majorly has the spine and the rib cage. So all the conditions that affect the spine would be included in that. What are the conditions? Like pot spine, storage disorders like mucopolysaccharidosis, spondyloepiphyseal dysplasia. All of these conditions would be included here. Vertebral anomalies. Right? So all of these conditions would be affected. Any condition that affects my spine would be included over here in short trunk dwarfism. Right? So this completes an important topic of short stature. Here, briefly, I want to mention this mid-parental height. This was asked in one of your exams, right? They asked you to calculate the mid-parental height of the child. So how do you calculate the height, the target height? We calculate the target height depending upon the height of the parents. We add the height of the mother and father and divide it by 2. That is average the height plus minus 6.5 centimeter. If it is a boy, then we add 6.5 centimeter. If it is a girl, we subtract. Right? So this is about target height, mid-parental height. So we are done with two major important topics, that is neonatal resuscitation protocol and short stature. And I covered a lot of MCQs here and there. Right? Make sure you have your concept straight and you mark the answer correct. Moving down to certain important milestones. Milestones, just before the exam, go through them because they're very volatile. Here I am discussing only the important ones. Look at this child. This child is sitting with support in a tripod position. Right? Sitting with support. This is tripod position. Tripod position. Where does this sitting with support comes? It comes around 6 months of age. And this is sitting without support. And when does the child sit without support? The child sits without support at 8 months of age. Right? Look at this. The child is moving on all the 4 limbs. In picture A, the abdomen is touching the ground. In picture B, abdomen is lifted off the ground. Which is crawling, which is creeping? When the abdomen is touching the ground, this is crawling. Crawling. And when the abdomen is off the ground, this is creeping. Creeping. This comes at 8 months of age. This comes at 10 months of age. What is this? The child is holding a toy in between the thumb and the index finger. This is pincer grasp. This is pincer grasp. Is this mature pincer grasp or immature? This is immature because the child is using the accessory fingers also. Right? If there is okay sign like that, the object is just in between the thumb and the index finger, no other accessory fingers have been into the use, then that would be mature. This right now is immature. Right? When does this immature pincer grasp comes? It comes by 9 months and mature will come at 12 months. Here, look at this girl, this pretty girl. This pretty girl is standing without any support. When does standing without support comes? The child can stand without support at 12 months of age. So by the first birthday of the child will be standing independently and cutting the cake. right? So this is standing without support. Some of the important milestones we have discussed over here. Moving down to some important deficiencies, right? The first deficiencies I want to talk about is zinc deficiency. Either they are going to give this picture or they're going to give a clinical scenario, and the clinical scenario will include three things. DAD. What is DAD? Dermatitis, alopecia, and diarrhea. And they will give you this typical explanation of the rash or the picture of the rash where you notice perianal rash, perioral rash. What is this? This is zinc deficiency, right? And what is this constellation of symptoms called as? This is acrodermatitis enteropathica. Acrodermatitis enteropathica, right? This is zinc deficiency. Apart from that, two important deficiencies: copper deficiency, kinky hair disease, the hereditary copper deficiencies, right? What is that called as? What is that called as? Menkes disease, right? And what about the selenium deficiency? That is Keshan's disease, right? Cardiomyopathy is the feature over here. And here the typical feature is kinky hair disease. Apart from that, other neurological features could also be noted. Moving down to the next topic, that is congenital diaphragmatic hernia. What is congenital diaphragmatic hernia? We all know what is diaphragm. Diaphragm is a muscle that separates your thorax from your abdomen. If congenitally there is a defect in that diaphragm, what would happen? The contents of your abdomen will migrate into the thorax, right? So the contents of the abdomen will migrate into the thorax, and this intestine that has migrated upwards won't allow the lungs to expand. So there will be pulmonary hypoplasia. The lungs won't grow, and ultimately it can lead to pulmonary hypotension. And we have discussed the CDH earlier also when we were talking about bag and mask ventilation, because bag and mask ventilation is contraindicated over here. Here you have to intubate the baby to ventilate, right? What are the important features that you need to know over here? That how will the child present? Obviously, because the lungs have not got any enough space to expand, the child would have respiratory distress. Also, the contents of the abdomen have migrated into the thorax, so my abdomen would be empty. So the child is lying down like this. I will notice a hollow abdomen. This is known as scaphoid abdomen. If I auscultate the chest of the child, I would hear the gurgling sounds of the gut in the chest. And because of this migration of the intestine upwards, there will be shifting of the heart to the opposite side. There will be shifting of the apex beat. So these are the important clinical features that you are going to appreciate over here. There are two types of congenital diaphragmatic hernia. It could either be anterior or posterior. You can see anterior hernia is actually anterior-medial hernia, and posterior hernia is actually posterolateral hernia. Which is more common, anterior or posterior? Posterior is more common. Posterolateral hernia is more common. And on which side, right or left? On left side it's more common. The special names are given to these hernias. The anterior-medial hernia is known as Morgagni's hernia, and the posterolateral hernia is known as Bogdanov's hernia. With ultrasound, antenatal ultrasound, we can detect them as early as 16 to 24 weeks, and after birth, by clinical examination, by looking at the chest x-ray, where you will notice this gut within the chest, right? We can detect these congenital diaphragmatic hernias, right? So we have completed 7 topics by now. Moving to the next topic, very important topic, malnutrition. And in malnutrition, an even important one, extreme forms of malnutrition, that is kwashiorkor and marasmus. Kwashiorkor and marasmus, right? Very easy topic. So look at the baby A, look at the baby B. Look at the baby A and baby B, right? Baby A looking very kekeksik, right? Skin and bones baby, as if the fat has been destroyed over here. Skin and bones baby. And look at the baby B, very edematous baby, very lethargic lying baby, right? So which is kwashiorkor, which is marasmus? Baby A is the marasmus baby, where the baby has been using all the resources of his body and now has turned into skin and bones. Can you notice this baby is very alert? If you offer food to this child, the marasmus child, this child is going to have a voracious appetite, will eat a lot of food. If the normal appetite of this age child is one chapati, he might eat 3 or 4 chapatis, right? On the other hand, B, kwashiorkor child, very apathic child, lying listlessly on the bed, right? Won't be interested in having food. If you offer food, won't have any appetite to digest it. Which of these would be having a poor prognosis, A or B? B is going to have a poor prognosis, right? A has a good appetite. He will eat and gain weight at one point. But B baby has lost the appetite, has developed edema, and sooner or later would succumb to comorbidities or mortality, right? So let's look at some differences over here. Kwashiorkor and marasmus. Firstly, wasting. Do you see wasting in kwashiorkor? Yes, wasting is there, but it is hidden by edema. It is hidden by edema. What about marasmus baby? What about marasmus baby? Marasmus baby is very thin. I can visibly see wasting. So there is severe visible wasting. Severe visible wasting. What about the onset? Usually kwashiorkor onset is after 1 year of age when the diet is changed from a milk-based diet, that is the mother's diet or a protein-rich diet, to a protein deficit diet, right? Carbohydrate-rich diet. Whereas marasmus can happen anytime, right? Anytime. It can happen at any time, less than 1 year also. The main deficit here is the protein deficit, whereas here the main deficit is calorie deficit. What is the appearance over here? In kwashiorkor, the baby is very apathic, right? Such type of baby, edematous baby, is also known as fat sugar baby. On the other hand, my marasmus baby is very alert. Also, appearance is that of a skin and bones baby. Skin and bones baby. Coming to the appetite, kwashiorkor baby, very apathic. Appetite is very reduced. Here the appetite is increased. The child has voracious appetite. Prognosis would be poor over here. Prognosis here would be better. Coming to the additional features, there are certain skin and hair changes. Skin and hair changes that are more appreciable in kwashiorkor baby. Can be seen in both, but more appreciable in kwashiorkor baby. What are these skin and hair changes? Can you notice here? There are patchy skin, patchy skin, right? Areas of hyperpigmentation and hypopigmentation. This is known as crazy pavement appearance. Crazy pavement appearance. Right? Look at the hair here. Hyperpigmented. This is known as flag sign. And lastly, can you see here peeling of the skin? Again, hyperpigmented or peeling of the skin. This is known as flaky paint dermatosis. So this skin and hair changes, crazy pavement appearance, flag sign, flaky paint dermatosis. All of these are skin and hair changes that you can see in both kwashiorkor and marasmus, but more commonly seen in kwashiorkor babies, right? And if you look at the liver over here, liver would be fatty liver. On the other hand, here the liver would be atrophic, right? So these are the changes that you need to know. After kwashiorkor and marasmus, an important topic is SAM, and in SAM, I need you to remember the definition of SAM. What is the definition of SAM? To define a child as SAM, that is severely acute malnourished, a severe acute malnourished child, I need any one out of three. What is that any one out of three? Weight for height less than -3 standard deviation. The MUAC, mid upper arm circumference, less than 11.5 centimeter. And there should be bipedal edema, bilateral edema, pitting edema, apart from other causes. That means nutritional edema. Any one out of these three, I would label the child as SAM. Here the important topic is MUAC. Remember, this MUAC is an age-independent parameter that we employ for 6 months to 5 years of age. And for community screening, we have a specialized tape, a colorful tape. What is that tape known as? Sharker's tape, Sharker's tape, right? So these are the important pointers for malnourishment. Moving to the next topic, differentiating a preterm baby and term baby. Right? We have expanded new Ballard score by which we can estimate the gestational age, but physically and some neurological parameters that you should know to differentiate a preterm baby from a term baby. Firstly, remember that a preterm baby will have very low tone, right? So the tone of the baby is less. So if the baby would be lying down, because of this low tone, the posture would be an extended posture. On the other hand, a term baby with a good tone will have a flex posture. Because of this tone only, if you go and attempt scarf sign, what is scarf sign? If I take the hand of the baby and roll it back, roll it to the other side of the shoulder, right? To the other shoulder, as if you're holding a scarf, you're wearing a scarf. This is known as scarf sign. If the tone is high, definitely my elbow won't cross the midline. If my tone is low, elbow would easily cross the midline. So I know in preterms the tone is very less. So while doing the scarf sign, elbow will cross the midline. On the other hand, in term baby, it won't cross the midline. Physically, if you look at the breast buds, they won't be developed in a preterm child, right? They won't be developed less than 5 mm in a preterm child, whereas they would be very well developed more than 5 mm in a developed child or a term child. If you look at the ear recoil, what is ear recoil? If I touch the ear like that and wait for the recoil, if I fold the ear and wait for the recoil, in a term baby, the cartilage is very well developed, just like our ears. So I can notice in my ear, the recoil is immediate. So in term baby, you will notice an immediate and fast recoil. But in a preterm baby, because the cartilage is not very well formed, it is very soft, this recoil would be very slow. This recoil would be very slow. Coming down to a very important differentiator, the genitalia. I know in a term baby, what would happen? In a male term baby, the testes would be distended, my scrotum would be pigmented and will have rugosity. It will have a rough surface, rugae would be there, right? This is for the males. And what about females? I know labia majora covers the minora. This is for term. But what about preterm? In preterm, if you look at the male genitalia, then the testes are not descended, testes are undescended. If you look at the scrotum, then the scrotum won't be pigmented, it would be pink. There won't be any rugosity, rugosity would be absent, it would be smooth. And in females, as we know in term, majora covers the minora, but in preterms, this majora and minora would appear equal to you, right? So this is the male differentiators between a preterm as well as a term baby. Now moving down to the next topic, neonatal reflexes. In neonatal reflexes, very factual topic, right? Here what is important for you is the appearance and disappearance of different reflexes. First reflex is the palmar grasp. You all know what is palmar grasp. If I stroke the palm of the baby, reflexively the baby will hold that. This is palmar grasp, right? The baby is not liking that object, it is just a reflex that the baby is grasping it, right? When voluntary grasp has to happen, then this reflex will go. So when this reflex appears at 28 weeks of gestation age. It is fully developed by 32 weeks and by 2 to 3 months postnatal, this disappears. What is important for you is the onset and the disappearance. Onset and the disappearance. Moving down to the second reflex, rooting reflex. What is rooting reflex? If I stroke the cheek of the child, what will the child do? The child will turn towards that stimulus in the order to search the breast. Right? This is rooting reflex. When does this rooting reflex appears? This appears around 32 weeks, fully developed after 34 weeks, and it becomes less prominent 1 month postnatally. 1 month postnatally. Then comes the third reflex, Moro's reflex, a very important reflex, right? A sudden extension, a sudden dropping of the head, the body of the baby would lead to an embrace reflex, Moro's reflex. There is abduction, extension, adduction, flexion, and sometimes the fifth component, cry, is also included. When is the onset of this reflex? When is the onset of this reflex? The onset is 28 to 32 weeks. Fully developed at 37 weeks. And 5 to 6 months postnatally it disappears. 5 to 6 months postnatally it disappears. Then comes the asymmetric tonic neck reflex. What is asymmetric tonic neck reflex? If I turn the head of the child to one side, what will happen? This to the side with which I have turned this child, on that side the upper limb and the lower limb will undergo extension, and on the opposite side they will undergo flexion, as if I am holding a bow and arrow, right? As if I am holding the bow and arrow. Both upper limb and lower limb will undergo extension on the side to which I have turned the face, and the opposite side will undergo flexion. This will prevent the child to roll over. So when rollover will come, this reflex has to disappear. So when is the onset of this reflex? 35 weeks. And when it is fully developed? 1 month postnatally, and it has to disappear around 6 to 7 months so that now the baby can roll over. Lastly comes the parachute reflex. This reflex appears after birth, 7 to 8 months after birth, fully developed around 10 to 11 months, and it never disappears. It never disappears, right? So a very important question: which reflex never disappears? Parachute reflex never disappears. Which reflex appears post birth? Parachute reflex appears post birth, right? Which reflex is fully developed post birth? Asymmetric tonic neck reflex is fully developed post birth, right? So some important questions would be there from this table. Purely factual topic, you unfortunately have to mug all of this, right? So before your exam, please go through this appearance and disappearance of different neonatal reflexes. Moving down to the next question, cyanotic heart disease. Next topic, cyanotic heart disease. Right? Cyanotic heart disease, a very vast topic. Congenital heart disease, a vast topic. But what FMG people are very fond of asking is congenital heart disease that have raised pulmonary blood flow and congenital heart disease with decreased pulmonary blood flow. Right? Physiologically, cyanotic congenital heart disease I can divide either into these two categories. When there is high pulmonary blood flow, the picture would be like this. There will be pulmonary plethora, right? If you look at the chest x-ray, it appears white to you, right? Because the blood flow is high over here. This is plethoric chest x-ray. On the other hand, when there is decreased pulmonary blood flow, the x-ray would look like this. Because the blood flow has decreased, now only I see black air. This is oligemic chest x-ray, So in which all conditions you will see decreased pulmonary blood flow? If you know, this is my heart. Right side of my heart will give blood to the lungs, right? So any problem at the right side of the heart, any restriction at the right side of the heart would lead to decreased pulmonary blood flow. So if this valve, tricuspid valve, becomes atretic, tricuspid atresia, there will be decreased pulmonary blood flow. What is the second condition? Where there will be pulmonary stenosis. Pulmonary stenosis is also a component of the tetralogy of Fallot, which is an important cyanotic heart disease. In fact, the most common cyanotic heart disease, right? So the second would be tetralogy of Fallot because of this pulmonary stenosis, right? What about increased pulmonary blood flow? Various conditions are there where there is a one channel of both this right and the left side. What is that? Truncus arteriosus. Right? Second would be TAPVC, total anomalous pulmonary venous connection. What else? Transposition of great arteries and hypoplastic left heart syndrome. Right? So remember these important classification of cyanotic heart disease, where you are going to see decreased pulmonary blood flow or oligemia, and where you are going to see increased pulmonary blood flow or plethora, right? Moving down to the next topic, drug of choice in nephrotic syndrome. Drug of choice in nephrotic syndrome. What is the drug of choice in nephrotic syndrome? Most common nephrotic syndrome in children is minimal change disease, and the drug of choice here is nothing but steroids. That is prednisolone. Prednisolone. How do we give prednisolone? We give 6 plus 6. That is 6 weeks of daily steroids and 6 weeks of alternate day steroids. 6 weeks the dose is 2 mg per kg per day, and for the alternate day steroid therapy the dose is 1.5 mg per kg per day. Right? The second question they ask over here is drug of choice in steroid resistant nephrotic syndrome. Remember, whenever the term resistant comes to you, remember by the mnemonic, spores are resistant, right? So here the answer would be cyclosporin, tacrolimus. Cyclosporin and tacrolimus, calcineurin inhibitors, right? The third question would be drug of choice in steroid dependent nephrotic syndrome. In dependent nephrotic syndrome, remember, if it is an uncomplicated scenario, the answer would be levamisole. If it is a complicated scenario with steroid toxicity, then the answer better would be cyclophosphamide or MMF, that is mycophenolate mofetil. Right? So this is about the drug of choice in nephrotic syndrome. Moving down to the next topic, drug of choice in various seizure disorders. Various seizure disorders. Firstly, in neonatal seizure, what would be the drug of choice in neonatal seizure? It's phenobarbital. In childhood seizure, generally to abort the seizure, we use benzodiazepine. So the better answer would be midazolam or lorazepam. Now coming to different seizure epilepsy syndromes, right? So in absence seizures, what happens in absence seizures? There are brief episodes of vacant staring look, usually seen in school-going children. Right? Here the drug of choice is ethosuximide. What is the EEG finding that we see here? We see 3 heart spike and wave complex. If ethosuximide is not in the option, then the second best answer would be valproate. Right? Moving down to West syndrome or infantile spasm. Here the drug of choice is nothing but ACTH. In the new guide, they have mentioned ACTH. Okay. So let's resume. Next topic is cystic fibrosis. What is cystic fibrosis? It is a genetic disorder. What is the inheritance over here? It is autosomal recessive. Which chromosome is affected? Chromosome 7. Long arm or short arm? Long arm of chromosome 7 is affected, which has the CFTR gene, that is the chloride channel transporter. Right? What this chloride channel transporter does? It transports chloride from intracellular to extracellular site. And as this negative ion is transported to the extracellular site, a positive ion sodium also follows. And with sodium and chloride in flow, water also follows. Right? So the basic purpose here is to thin out secretions. So if this channel is defective, what would happen? The secretions won't thin out. There will be very thick secretions, mucoid secretions, viscid secretions, also known as mucobiscidosis. And because of this thick secretions, clearance would also be affected, leading to recurrent pneumonias, recurrent infections. Right? So this is what happens. What they ask in the exam is, what is the most common mutation? A lot of mutations, thousands of mutations have been detected in CFTR. The most common mutation is delta F508. That is, delta is for deletion, F is phenylalanine. So deletion of phenylalanine at the 508 position is most common mutation. Then comes the diagnosis. What is the diagnostic criteria of cystic fibrosis? Typical clinical features of cystic fibrosis: detection of any history of family or sibling history, or 2 mutations, right? And certain lab test that includes 2 cystic fibrosis mutations, increased sweat chloride, and abnormal transepithelial nasal potential difference. And this is your pharma question. They ask about the CFTR modulators that modulate this transporter function. 𝑭𝒂𝒂𝒃𝒃, 𝑭𝒂𝒂𝒃, 𝒂𝒂𝒃, remember caphtor with the CFTR, right? Caphtor and CFTR. All of these is about cystic fibrosis. Moving down to the next question, congenital hypertrophic pyloric stenosis. Congenital hypertrophic pyloric stenosis. Again, an overlap topic with surgery and also important in pediatrics. It is most commonly seen in the firstborn males. What happens over here? The name itself, congenital hypertrophic pyloric stenosis. So at the pyloric end of the stomach, there will be hypertrophy of the circular muscles. And because of this hypertrophy, what would happen? There will be gastric outlet obstruction. So what will happen? The child will vomit out whatever the child is having. So there will be recurrent vomiting. What type of vomiting would be there? Bilious or non-bilious? Bile opens into the duodenum, right? Here the obstruction is prior to that. So there will be recurrent non-bilious vomiting. And what else is there in my stomach? There is gastric acid, gastric juices. They would also come out. So there will be expulsion of the hydrochloric acid. There will be expulsion of electrolytes, water. So there will be dehydration. And because of this loss of this acid, there will be alkalosis, right? So there will be hypochloremic metabolic alkalosis. Because of this dehydration and hyponatremia, my RAS will get activated. This RAS will do sodium correction. And by the help of sodium correction, how does it correct the sodium? It absorbs the sodium and excretes H plus and K plus. So in the urine, paradoxically, there will be aciduria. My body is in alkalosis, it should preserve the acid, but because of this RAS activation, there is aciduria. So the clinical picture here would be hypochloremic metabolic alkalosis with paradoxical aciduria. The treatment is nothing, but we have to do the dehydration correction, electrolyte management, and the definitive surgery is Ramsdell's pyeloromyotomy. Right? So this is important topic, CHPS. Moving down to the next topic, that is diarrhea and dehydration assessment and management. Firstly, diarrhea in pediatric population. They're classified as acute diarrheas, chronic diarrheas, and persistent diarrheas. What is an acute diarrhea? A short duration diarrhea, less than 7 days diarrhea, usually due to infective cause. Very common, right? What is persistent diarrhea? If this infective diarrhea persists for more than 7 days, more than 14 days, this is nothing but persistent diarrhea. Then comes the term chronic diarrhea. This chronic diarrhea term is reserved for non-infectious diarrheas. Maybe the diarrheas that you see in malabsorption syndromes, right? Here the duration would be more than 14 days, but the cause is non-infectious. Remember, what is the most common cause of diarrhea in children? Is it bacterial or is it viral? It is viral. Viral diarrheas are more common as compared to bacterial. And what is the most common viral diarrhea? It is the rotaviral diarrhea. What is the most common bacterial diarrhea? The one caused by enterotoxicogenic E. coli, ETEC. Diarrhea has changed in frequency or consistency at the schools. If along with diarrhea there is blood in stools, this is known as dysentery. And what is the most important organism here? The most important organism here is Shigella flexneri. Shigella flexneri. So important thing in diarrhea is you have to firstly assess the level of dehydration that this diarrhea is causing, and depending upon the level of dehydration, we give treatment. Right? So let's see how would you classify dehydration. Dehydration, no, some, severe. Right? So a child with loose stools vomiting would either be no dehydration, some dehydration, or severe dehydration. First, look at no dehydration. This child has no dehydration. So how would this child look to you? The child would appear normal, would be alert, right? If you do skin pinch in this child, then the skin turgor is normal. So there would be fast recoil. Oral mucosa would be moist. Eyes will look normal to you. If you offer water to this child drink water very calmly, very gentleman-like. That means thirst is normal. This child has no dehydration. Here I will give plan A. Plan A. We will discuss what is plan A, plan B, plan C. Right? So firstly remember, no dehydration child will look alert to you, normal to you. The oral mucosa would be moist. Skin pinch would have fast recoil. The thirst would be normal. The eyes would look normal. Now let's move down to some dehydration. Now some degree of dehydration has set in. Some degree of dehydration has set in. So this child would be very irritable child, very irritable looking child. If you do skin pinch, now the skin turgor has decreased. So the recoil would be slow, but it would be less than 2 seconds, less than 2 seconds. It will take about 2 seconds to come back. The oral mucosa will be dry, the eyes would look sunken. The child would be very thirsty, very irritable and very thirsty child. If you give water to this child, the child will very eagerly drink all that water. This is some dehydration. We give plan B over here. And lastly, there's severe dehydration. What do we do in severe dehydration? What do we look in severe dehydration? In severe dehydration, the child would now be very lethargic. In some, the child was irritable. Here, the child would be completely lethargic, comatose. If you offer the child is comatose, lethargic, won't drink any water. The eyes would be very sunken. The oral mucosa would be very dry, right? And if you do the skin pinch, it would be very slow recoil. More than 2 seconds it will take. This is severe dehydration. This is plan C. In plan A and B, we do oral rehydration because the thirst is intact. But in plan C, we have to give IV-RL fluid. IV-RL fluid. Right? So plan A and B, we will do home management, give oral rehydration solution and explain the danger signs. But in plan C, I have to do hospital management and give IV fluids. The management is very simple. In plan A, there is no dehydration. So we just replace the ongoing losses with ORS. In plan B, we firstly correct some degree of dehydration. So how do we rehydrate the child? We give 75 ml per kg of the ORS over 4 hours. And apart from that, we ensure that the child has enough maintenance fluids orally. And in plan C, severe dehydration, the rehydration would be IV through RL, ringer lactate. How do we give that? We give 100 ml per kg. Over how many durations? Depends upon the age of the child. If it is less than 1 year, then 30 ml per kg is given over 1 hour and rest 70 ml per kg is given over 5 hours. If the child is more than 1 year, then half hour and 2.5 hours. Apart from that, we have to replace the ongoing losses and ensure maintenance fluids. Right? So this is all about the management of dehydration. Remember, in pediatric diarrheas, don't ever forget, even in adult diarrheas, don't ever forget zinc supplementation. Less than 6 months, we give 20 mg per day, 10 mg per day, and after 6 months, 20 mg per day. And this you have to give for at least 14 days. Right? In the beginning, we discussed what is more common, bacterial diarrheas or viral diarrheas. Viral diarrheas are more common, right? So that means, is there any role of antibiotics in pediatric diarrhea? No, generally we don't give antibiotics in pediatric diarrheas. We just assess the dehydration, manage the dehydration and give zinc. But there are certain situations where I will give antibiotics. What would be that situation? If there is dysentery. Dysentery, that means there is blood in stools. And dysentery, I know the organism is Shigella flexneri, which is a bacteria. So in dysentery, we will add third generation cephalosporin. If there is rice water stools, that means cholera, a sign of cholera. Here, I would add doxycycline. If this is a SAM child or an immunodeficient child, in that case, I will add antibiotic. If there is severe sepsis signs, then again I would add antibiotic. These are the some situations where antibiotics are indicated in childhood diarrheas, right? So this is all about the diarrhea management. Moving down to the next topic, X-rays in congenital heart diseases, right? Look at this X-ray. What all can you appreciate over here? I can see this sign. What is this sign? 3 sign. And what is this? This is inferior rib notching. Can you notice? Notching in the inferior border of the rib. Inferior rib notching. Where do you see this 3 sign in the inferior rib notching? We see this in coarctation of aorta. Coarctation of aorta. right? Moving down to this, what can you see over here? Typical boot-shaped heart. Where do you see this boot-shaped heart? Of tetralogy of Falley, right? Look at this image. What can you see over here? This is egg on string appearance, right? Can you appreciate over here? Egg on string appearance. Where do you see this egg on string appearance? This is seen in TGA, transposition of great arteries. What about this box-shaped heart? Box-shaped heart. Where do you see this box-shaped heart? If the mother is suffering from bipolar disorder and taking lithium, the baby can have this anomaly. What is this anomaly? This is Epstein anomaly. Epstein anomaly. Right? And lastly, look at this heart. What is this? Figure of 8 appearance. Figure of 8 appearance or snowman appearance. Where do you see this? We see this in supracardiac TA-PVC. Supracardiac TA-PVC. In infracardiac, we see white out lung. Supracardiac TA-PVC, you see this figure of 8 or snowman appearance. Right? So these are the important chest X-rays in congenital heart diseases. Moving to the second last topic of the session, LTP group. Again, an overlap with ENT, right? So we'll be just discussing important points over here. LTP and group. Look at the X-ray A, look at the X-ray B. What sign can you notice over here? What is the sign? Steeple sign. Where do you see the steeple sign or pencil tip sign? In laryngotracheobronchitis or group. What sign are you going to appreciate over here? What is the sign? This is thumb sign. Thumb sign. Can you notice this? This is thumb sign. Where do you see this thumb sign? We see this in acute epiglottitis. Acute epiglottitis. Right? Which is caused by a bacteria, which is caused by a virus. Acute epiglottitis is caused by a bacteria. This is caused by a virus. Which is an acute emergency and requires hospitalization. Acute epiglottitis. Which one has barking, cough, seal-like? This is LTB, right? So let's look at some major differences. First, let's talk about group. The age group here is 6 months to 5 years. Cause is a virus. Which virus? Parainfluenza virus. There will be low-grade fever, stridor, and a typical cough that is known as barking cough, seal-like cough, or brassy cough. Right? The management is based upon the severity. We usually give nebulization with racemic mixture of epinephrine. Right? And what about acute epiglottitis? Age group here is 1 year to 3 years. The cause is bacteria. Which bacteria? H. influenza type B. This child would be more sick looking, will have high grade fever, stridor, drooling saliva, and the child will be sitting in a typical posture of a tripod posture or a sniffing dog posture. It is an emergency. Stabilize the child and stabilize the child ABC and give antibiotic, third generation cephalosporins. Right? Now coming down to the last topic, that is pneumonia IMNCI guidelines. Remember diarrheas in children? We discussed which is more common in pediatric population, bacterial diarrheas or viral diarrhea? Viral diarrhea. But what about pneumonia? Which is more common, bacterial or viral? Bacterial pneumonia is more common. And amongst the bacteria, which is the most common bacteria? That is Streptococcus pneumoniae. Most common viral cause is RSV, that is respiratory syncytial virus. Most common cause of bronchiolitis in children is also RSV, right? So commonly the below 1 year wheezers, they are having bronchiolitis, right? So in that case, the most common causative organism is RSV. In immunocompromised children like HIV/AIDS, the common organism is Pneumocystis jirovecii, and in atypical age group or adolescent age group, Mycoplasma pneumoniae is the culprit. Right? What is important for you are the IMNCI guideline. As in diarrhea, we had no dehydration. Dehydration, we had no dehydration, some dehydration, and severe dehydration. Here we have no pneumonia, pneumonia, and severe pneumonia. There is no some pneumonia, there is just pneumonia, right? Either no pneumonia, pneumonia, or severe pneumonia. In no pneumonia, what would be happening? The child will just have URI symptoms, upper respiratory infection symptoms. There will be cough, cold, and fever. There will be no signs of respiratory distress. The saturation of this child would be normal. Nothing has to be done. You just give supportive medication for this child, right? What happens in pneumonia? Here, along with cough, cold and fever, child would have increased respiratory rate. The respiratory rate would be increased. But here the saturation would be normal. Saturation would be normal. This child would require an antibiotic course. We give 5 days of antibiotics and tell the danger signs to the mother or the caregiver. If any of the danger signs appears, they have to report back, right? And lastly comes severe pneumonia, where along with tachypnea, there will be chest retractions, there will be any other danger sign. This child would require immediate administration of IV antibiotic and referral to the higher center for further management. Right? Remember these two. What is the criteria for fast breathing? Depending upon the age, 0 to 2 months, 2 months to 12 months, or above 12 months. More than 60, more than 50, more than 40. Right? So if a 2-year-old child comes to you with a respiratory rate of 48, that would be tachypnea, right? And what are the danger signs? Any of the danger signs, if there, that would be severe pneumonia. The child is unable to drink. The child is abnormally sleepy. If there is a stridor in a calm child, if there is severe malnutrition, all of these are the danger signs that you have to look for in the STEM. In the question STEM, they would be giving you a child. They will be telling you the age group. They will be giving you the respiratory rate, right? Check if the respiratory rate is normal and there is no danger sign, then this is no pneumonia. If the respiratory rate is high, but there is no danger sign, this is pneumonia. If the respiratory rate is high and there is some danger sign also, this is severe pneumonia, right? And depending upon that, they will be asking the management. If there is no pneumonia, the management is nothing, just supportive medication. If it is pneumonia, then oral antibiotic amoxicillin. If there is severe pneumonia, then you have to give IV ampicillin gentamicin and refer to higher center. So this completes the 20 short topics of pediatrics. I hope the session was helpful for you. And if you don't have enough time, I would say that please go through these topics prior to your exam, right? Simply the volatile ones like milestones and neonatal reflexes, the appearance and disappearance, because these are very factual topics, right? And very easy to forget these topics if not revised at the same time. That's it. Thank you for the session. All the best for your exam. I wish that all of you pass with flying colors, and I wish to meet you on the other side with your amazing scores, and all the best for your internship further. Thank you.